Dr. Gupta is a PGY5 child neurology resident with the U of L School of Medicine. He completed medical school at Jawaharlal Nehru Medical College in India and a pediatrics residency at All India Institute of Medical Sciences in New Delhi, India. Dr. Gupta will be doing a neuroimmunology fellowship at the University of Nebraska next year. And he will be talking about the Neonatal Neurologic exam. And his mentor on this talk was Dr. Arpita Lakhotia. She is a child neurologist with Norton Children's Neuroscience Institute, affiliated with U of L School of Medicine, and she is an associate professor. She completed her pediatrics residency and child neurology fellowship training at Case Western Reserve University and Rainbow Babies and Children's Hospital in Cleveland, Ohio. And she joined the Department of Neurology here as faculty in 2016 and now serves as director of Norton Children's Pediatric Stroke Clinic and director of Norton Children's Muscular Dystrophy Clinic. So thank you, Dr. Gupta.
All right. Well, I hope everyone can hear me okay. And I'll try to move quickly. But I think I'm going to basically focus on the general idea of neonatal neurological exam today rather than the nitty-gritties and finer details, because you will see throughout the day there will be more and more discussions about those. So with this presentation, I really want to highlight the schema of neonatal neurological exam, what is the variability across different gestational ages for a baby in terms of the neurological exam. I also want to appreciate the wide range of, as well as the dynamicity of the exam in newborns at different times. And then some of the common misdiagnosed variables that we see in neurological exams. So I want to sell this to you guys first. Why do you want to do a neonatal neurological exam? It takes 20-25 minutes to do it. And it can be very tricky in patients who are very tiny. So for the people who are taking care of community pediatricians, the nurses who are in the floor, in the hospital and taking care of the babies, I think they need to know a little bit about neurological exam in babies, just because sometimes we have had those surprises where you are finding these patients, they don't just look normal, there's something wrong with them, and that leads to a neurology consult and then a full workup, and then reveals a diagnosis. So that's important. And also, I know we joke about it a lot that babies, all they do is eat, sleep, and they're mostly like brain stems. But honestly, they are not. There is much more in there. And picking those things can help also early detection of a lot of disorders. Same thing for the pediatricians who are seeing these babies outpatient. We all know birth is a major at-risk event for babies' brains, so they can have seizures, HIAs, intraventricular bleeds. There are examples where we had babies who were having seizures from day one of life, and they were missed, and then later on found to have those seizures, which they were probably having from day one of life. So early identification can help in those cases, not only to treat them, but also maybe improve their long-term outcomes. So it is busy, it's very complex, and I know it takes a long time, but I think we should still try to practice at least a part of the neurological exam of babies. In terms of the components, it's essentially similar to what we do for neurological exam of adults or older children in terms of the schema. From general exam to higher mental function, cranial nerves, the motor exam, maybe a little bit of sensory exam, but neonatal reflexes. And then in terms of general exam, the main aim of finding possible issues on general exam is to relate them with neurological diagnoses. So of course, we're going to look at the weight and overall head circumference, which kind of indirectly reveals brain size and brain volume in babies, all the way through gestational age, presence of dysmorphism, the fontanelles, the skin in general, because if you guys recall, most of the brain tissue is actually derived from ectodermis, the same tissue from which the skin is derived. So, and then also looking for skin defects like sacral dimple. So just making sure that we are picking up certain things on general exam makes a little bit more important in terms of finding neurological abnormalities and may indicate an underlying abnormality. So we all know about a modified Ballard scoring, and I just wanted to highlight why it is important to know neurological exam, because even in the modified Ballard scoring, you can see all those traits up on the neuromuscular maturity. They are actually part of neurological exam. So just to say. And then there are some pictures I wanted to show you guys about microcephaly. You can see how the head can become flattened on the frontal aspect if you're seeing a baby with microcephaly, and this could help detect mild to moderate microcephaly, which is just to say the head circumference less than third centile for age and for gestational age. The other important thing that we have found sometimes in our patients is bulging anterior fontanelle and premature closure of fontanelles, so or the sutures in general. So making sure that those are open and the fontanelles are not bulging. You can have normal bulging of fontanelles during crying and sometimes even with some viral infections, but for the most part, if you are seeing any fontanelle or bulging, that indicates there may be something going on inside the brain as well. In terms of higher mental function, so babies' higher mental function, it gets a little trickier than the normal adult higher mental function. Essentially, I want to highlight these 2 points in the bottom, like consolability and habituation. Both of them are the basic tenets of higher mental function for neonatal exam. The trick or the tricky part in this context is that babies circulate through different states. They cycle. They cycle from a light sleep, drowsiness, quiet sleep, active sleep, even crying. So there are different states that babies circulate through, and actually, if they are not going through those states and one state is persistent, that might indicate that there may be something going on, maybe like an encephalopathy. Also, it is important to note that you want to examine babies mostly during that quiet alert and maybe active alert state. If the babies are just finished with eating, they're in their light sleep stage, the neurological exam of higher mental function is not going to be very useful. So make sure that if sometimes you have to just come back again to do the exam, but I think that's the key here. There is a scale that I wanted to bring to you all's attention, the Newborn Behavioral Assessment Scale. It's an inventory of different items which looks at how the babies are doing in terms of their behavior. And it's an interesting theory on which it is based. The theory is that babies, their first function is survival. So they want to eat, maintain their temperature, maintain their energy. That's like their first task. And after this task is finished, then only they will go to the next stage where they're trying to regulate their activity, their reflexes. And then if that is maintained, then only they will maintain their actual states, the cycling. So it does require them to have a first and second step before they can actually regulate their cycles. So if they are not cycling, it means that maybe they're having problems with keeping their energy, or if they are maybe also not able to regulate their motor function. So making sure that those two are fulfilled first before you examine the patient or the baby, that's important. In terms of cranial nerves, it's essentially the same as older children and adults, with a little bit of caveat. For example, for pupillary reflex in response to light, which tests for, you all know, cranial nerve second and also third, it might not be present in babies who are too young. Sometimes, especially younger babies than maybe 28 weeks, you might not be able to get pupillary reflex because their nerves are not very mature. So it does follow, but over time you will be able to find them. So maybe if a baby is 28 to 34 weeks, you might want to just do their reflex response to light, like how they open their eyes and they grimace, rather than looking into their pupils. Doll's eye maneuver is good for the third, fourth, and sixth cranial nerves and the brainstem. Quality of crying for 9th and 10th, you can see the suck and swallow. It's a very complicated mechanism and involves several cranial nerves. Response to sound, turning response to stimulus. These all are true for older babies. Of course, you want to suck and swallow is not going to be very mature in a young, very preemie baby. Sometimes we get calls in from the emergency department and also from newborn nurseries that baby is having facial droop. And we get this kind of picture and figure out, oh, it's not facial droop, it's only an asymmetry of face when they are crying. So one of the things that I've seen sometimes, it's called congenital absence of depressor anguli oris, which is like a muscle that is supposed to open your mouth. So if it is absent on one side, it might falsely lead you to that conclusion. In terms of motor assessment, motor assessment in babies is largely limited to looking at them and assessing what kind of movements they are having, and a little bit of like the tone assessment. Dr. McCoy is going to talk more about tone assessment, so I might skip some of those parts, but then essentially we are looking at passive tone and active tone. Active tone means what the baby is doing when they are moving on their own, and then passively when you're trying to move them passively. So we can do certain signs, and I'll show you in some of the pictures here. This is on the right, on the top, there is something called as suspension, and you can see in a normal baby on the rightmost figure, you can see the baby's trying to lift the head up, and you can see the hips are flexed together, whereas a baby who is hypotonic, you can see the head is not picking up at all, and then the legs are straight and hanging down. The other one is ventral suspension. You can see the other one is pull to sit, where you can see the head lagging on the left picture as compared to the one on the right. Again, it suggests low tone in the neck muscles. And on this picture, on the left side, you can see the holding the baby, and you can see it's sometimes we also like set an example like a rag doll. So when you hold a rag doll, if they don't have tone, right? So they will just slip through your hands. But if it is a baby with good shoulder girdle muscle strength, you should not have that slippage. And just for an example, this is how a healthy newborn, term newborn's tone looks like. Their elbows are flexed, their hips are flexed, maybe some flexion of the knees too. And again, the tone varies through gestational ages. So maybe early on, maybe a 24, 26 weeker will have no flexor tone in their muscles. And as they advance, they will develop this kind of flexor tone. In terms of reflexes, we all know about the deep tendon reflexes that you can test. There are other primitive reflexes that these babies have, and essentially they are like an evolutionary reflex, which was probably taken from other animals. And the good thing about these reflexes are they help us differentiate between like a focal neurological deficit. So asymmetry is more important in terms of when you're looking at the reflexes rather than absence or presence of them. Again, most of these reflexes vary with gestational age, and most of them tend to disappear with age. So you can have suck and root, Moro's, Gallant, stepping, and grasp reflexes, and of course we all know about the grading of reflexes. So here I want to play, and let's hope it plays a video of how you can do a quick normal neonatal exam, courtesy Dr. Rogers and her baby. You can see the spontaneous movements of the baby. And sometimes all you need to do is just observe the babies, and you can tell, okay, they're doing good, they're not doing good. And in terms of their movements, in terms of their response, she's trying to test the tone here. This is, of course, she's trying to do the elbow scarf sign, as well as the tone in the lower extremities. is pulled to sit here. So you heard her, right? You can see some truncal tone over there. Some prone suspension. And then she's going to get that big hammer over there to get the routine reflexes. I was going to say having a good reflex is really key to do these reflexes in babies, especially since they have so tiny muscles and tendons. So she roots some here. Even more rooting. This is example of a state change. And here you can see consolability, which is a very important higher mental function. A motor reflex there. A better motor reflex there. All right, so you guys can see how if you are getting used to it and you're doing it every day and routinely on babies, it might not take a long time here to do the exam, especially if you're concerned. All right. And then I wanted to bring, so this is where I just stop the routine neonatal neurological exam and talk about other things that we are noticing and that they might become a part of neonatal neurological exam in future. General movements is one of those. It's a very important finding that was actually discovered several decades ago, that babies do different kinds of movements. And those movements, looking at them, those spontaneous movements can help us predicting whether they are at risk of having neurodevelopmental issues later in life. So there are certain nuances to it, like you have to do, basically what you have to do is you have to put the baby in a crib, make sure they're not feeding, they don't have a pacifier, they don't have anything in the bed, and record a video of about 3 minutes and see what kind of movements are they doing. Of course, the seer has to be an expert and trained in general movements. There are actually courses that you can do, and for one of our occupational therapists, it was harder than her board exam. So it is a skill that you acquire with repeated training. There are different types of general movements. I wanted to just you guys to pay attention to these two, writhing movements and fidgety movements. Fidgety movements are the ones which are more important in assessing neuromorbidity. That being said, you can also track the writhing movements over time. And of course, they are according to different gestational ages. There's a transition period in between where you might want to avoid doing that assessment. Writhing movements are useful for premature babies, and some people have actually described them as like chorioathetoid movements, which are like dancing movements. They have variable amplitude, and then they can have, they are graded into different scales. Like you can have a normal baby movement, you can have a poor repertoire writhing movement. Cramp synchronized is the one which I think I will like everyone to look at, because these are the ones which have been associated with cerebral palsy and neuropathology. So I a video of how cramp synchronous movements look like. They're more like if you are folding yourself, like a purse that opens and closes, and they are chaotic, and they are not as smooth as you will expect the normal movements. So that's cramp synchronous. And then fidgety movements, they are also followed more specifically between 3 to 5 months of chronological age. They become less amplitude and more smoother. And these movements have to be, again, followed. There are cases, actually, where you had a normal baby, a normal neurological exam, and then for some reason, somebody decided to do a general movement assessment, and they found that this patient had abnormal kind of fidgety movements and later discovered to have MRI abnormalities. So that is why they are so important to learn about, and maybe in future they will become part of our exams. And then, so just to summarize general movements, if you are suspicious of having somebody having neuromorbidity as a baby, then you can always try to see those by yourself, and or have them seen by an expert, like an occupational therapist who is trained in those, and they can play an important role in figuring out if they have there is a risk of cerebral palsy or not. There are several studies that have actually looked at the sensitivity and specificity of general movements plus MRI plus newborn exam, and they reach like 95% in terms of detection of neuromorbidity. So a really important thing to give a thought on. And then the last part, I want to just bring about briefly the Hammersmith Neurological Assessment Exam. This is kind of like a checklist of items, which is mostly based on neurological exam, but also some behavioral components. This can be administered in a clinic, in NICU. There are different items, 26 items, which score the global score as well as asymmetry, and they are also they also have been found on studies to have a good correlation with development of cerebral palsy. So this is just like a photo of what it looks like, and there are scores. You can sequentially follow those scores, and really asymmetry is one of the big ones. And then I will end by talking about how AI is changing everything. So maybe neonatal neurological exam will still be important, but you could do neonatal neurological exam with AI. So there's an app called, there's a software called Pose AI that basically, I'm not sure if anyone has used it here. It's more for workout and gym, where it kind of detects your movements, but it can also be used to detect babies' movements. So maybe there's this study specifically looked at EEG videos using Pose AI, and it had a high sensitivity in terms of detecting the babies who were going to have neurological abnormalities. So that is coming. All right. So I have some videos, but I think we have 3 minutes, so I'll try to play them quickly. But if anyone wants to participate, they're welcome to. On the right video, can anyone tell me what are we doing here? What all normal findings in a baby exam are you seeing? Some suck reflex and some following with the eyes. Great. Mm-hmm. Yeah. Yep. So like I said, it's more all about observation. I don't know if you guys notice anything. Well, this is, again, a normal baby, but anything on their exam that you find?
He's drowsy.
Yeah. So going to sleep or getting irritated by being examined. But you can see the flow of movements. There was like a really nice kind of flowy dance-like movement, almost like reminiscent of maybe some choreo movements, which is a normal baby description. And then here, oh, I should have turned the volume down. Medical students, anything you see over there?
The neck's not floppy, which is good.
Yeah, the neck didn't go down all the way. It didn't. So babies at term, they should be able to at least intermittently get it out, but sometimes you also have babies who are not able to do it right away. So I guess, so this baby did not correct it and made it at the level of the spine, but did not go down. Okay, anything there? Just a normal rooting and then consolability with rooting and sucking. Okay, good. All right, so to conclude, neonatal neurological exam is largely based on observations and requires patience. Setting a standard performer like a Hein exam sheet could be very useful and in kind of practicing yourself and developing that skill over time. Exam findings should be ultimately used in conjunction with other diagnostic aids. They're not perfect and they need to be longitudinally weighted. And I think from one thing I want to get from this presentation is early referral for risk babies. If you find something that's abnormal on neurological exam that you're doing in your clinic, just refer them because sometimes that makes a big change in their lives. And then I talked about the future directions. You might have an app on your phone that you might record a video and see what the babies are doing, and it will tell you how much prediction it can tell you that this is good or not. And then further biomarker development. All right. So I want to acknowledge Michelle, who's here, for her help with the general movements information, Dr. Lakodia, Dr. Means, and Dr. Puri for organizing this wonderful update. Thank you.